Margaret Chan, Director General of the WHO, Minister Gan Kim Yong, Minister of Health, distinguished guests, ladies and gentlemen. Very happy to welcome all of you to this ministerial meeting in Singapore. Your participation reflects the importance placed by all your governments on universal health care. And I would also like to acknowledge the important work done by the WHO to promote good health and to help us reach our shared goal. Enabling citizens to live full and healthy lives is one of the most important responsibilities of the government. Firstly, because good health is fundamental to the happiness, fulfillment, and dignity of every human being. Secondly, because good health is a public good. If a few people in a society get ill, it's not just them who are affected, but it affects the well-being of the whole society. The disease may be infectious, or at any rate, the loss to the society is to the community as a whole. The current Ebola outbreak in Africa and our experience with SARS a decade ago reminds us how disruptive and terrifying public health crisis and epidemics can be. But even short of an epidemic and a crisis, if some parts of society are sick or prone to disease, it affects everybody. Thirdly, good health is a basis for the nation's prosperity and success. Healthy children learn better, they have a much better chance to improve their lives. And healthy adults contribute to the workforce better and are more able to take care of their family and their loved ones. So good health is an intrinsically important goal, but good health for the whole population is very challenging to achieve. Because in healthcare, the usual economic models don't work very well. There's information asymmetry between healthcare providers, insurers, and patients. In other words, the doctor knows more than the patients, the doctor knows more than the insurance company, and the insurance company knows more than the government. So patients rely on medical professionals not just to advise them, but also to act in their best interests. And because there is not this check and balance where each side knows what it is doing and how to guard its own interests, the idea of willing buyer, willing seller, good outcome doesn't work. Secondly, if we try to protect patients from medical costs or from excessive medical costs when they fall ill, we create a moral hazard. Whether it's a generous insurance plan, whether it's a state-funded healthcare system, once you protect people from the consequences, the financial consequences of medical treatments, drugs, protocols, patients will seek more treatment than they need, and not just the patients, but the doctors too will be incentivized to overtreat because they will feel, perhaps out of goodness of heart, that it is their duty to do the best for the patient. Or they may feel, for a pecuniary motive, well, if I do more, I will be paid commensurately. But that's not the only problem with market failure. Even expanding the healthcare system's capacity to meet future needs may find ourselves chasing our tails, stimulating supply-induced demand and increasing the needs and the demand for healthcare. Once equipment and facilities are available, they will be fully used. It is very hard to run a hospital with beds kept empty. It's very hard to have an MRI and to say this patient doesn't need a scan. Patients get used to higher standards of healthcare and faster responses, even when these are not medically essential. And if later on you come back to more normal standards, there's a reaction. So slack capacity is quickly taken up, and we end up having to build more hospitals, more clinics, provide more services, need more doctors, spend more money. So healthcare is a place where we see many market failures. Therefore, we can't take a purist approach to design healthcare systems, but either based purely on laissez-faire markets or, at the other extreme, on a non-price dirigist command economy model. We need to use a variety of instruments: pricing, regulation, incentives, system design, public and private engagement efforts, exhortation as well as sometimes compulsion. And all to shape behavior. Behavior by doctors, by patients, by administrators, by drug suppliers, in order to produce a good collective outcome. And we also have to deal not just with healthcare in a narrow sense, but widen our perspective and deal with other areas that affect an individual's health. For example, public health. Or, for example, getting individuals to take personal responsibility for their health through their habits, through their lifestyles, through their exercise patterns. Therefore, the governments have to take this broader perspective, design a whole system so that different parts complement one another, and make wise trade-offs between outcomes and costs in order to make individual and collective choices which we cannot avoid making. Nothing is for free. There's always a limit to resources. Choices have to be made. Trade-offs have to be accepted. And once you have a system, you cannot rely on it to be self-adjusting. You have to constantly adapt and adjust the system to keep it in balance and functional, because needs will change, because the participants will learn about the system and start to optimize their behavior and game the system and result in pushing things out of kilter. And doctors do it, patients do it, all the participants responding to their individual incentives inevitably cause the system to be non-self-stabilizing, and the government has to try to keep a detached view and keep it on track. One key element in any healthcare system is how it is funded. You can do it one way, by a more privatized path, where you make individuals responsible for their own healthcare costs, and run private healthcare institutions. But this way, inevitably, some segment of the population will be left out, who cannot afford medical treatment. Either cannot afford the treatment when they get ill, or cannot afford the treatment when it's particularly severe disease and needing extra expensive drugs or procedures, or cannot afford the insurance which is needed to pay for the treatment. You can use insurance to mitigate this problem, but insurance inevitably results in higher total costs to the whole society because it encourages more use of healthcare services, and insurers then pass on the premiums to the companies or the individuals who pay for the insurance, and society as a whole bears a heavier burden. And one extreme example is in America, where up to 18% of the GDP is spent on healthcare. At the other end of the spectrum are single-payer systems, funded by taxes, where the state runs the healthcare institutions and picks up the whole tab. And the NHS in Britain is an example. It spends much less than the US, maybe about less than half, but healthcare is rationed by queues, and sometimes explicitly by excluding certain drugs or treatments. I mean, for example, in one instance, for some rare eye diseases and expensive to treat eye diseases, it is reported that the NHS agrees to treat one eyeball per person. But these are choices which have to be made. And the choice is made by the system, and the individual has not so much choice. So whichever way you go, there are trade-offs. And in Singapore, we face the same challenges and difficulties as other societies in delivering good health care, because these trade-offs and these problems are intrinsic to the healthcare delivery system. But given these difficulties, we've developed our own approach, and it's worked reasonably well for us. We've had some favorable factors which has helped our system to work. Firstly, as a new nation 50 years ago, we were able to learn from the experience of other more established countries which had built up their healthcare systems earlier than us. Secondly, we had a young population. So we were building up our healthcare system when the population was still young, active, and with a low disease burden. Thirdly, we enjoyed rapid economic growth, and therefore were able to improve our infrastructure, improve our public health standards, and at the same time educate our population to take better care of themselves, and also have more resources to invest in better health care for our people. So with these favorable factors, we developed our own approach, and let me share a little bit about it with you. 3 prongs particularly. First, we focus on public health. We invested in basic sanitation. We didn't start off with modern sanitation. Up until 40-odd years ago, there were still night soil collectors in Singapore. And there was a truck, and every day the night soil collectors will come and collect the pail from the house and then put it into the truck. And each truck has 36 doors, was a traditional description. And then these would trundle along the roads and you hope they don't leak. 40 years ago. But as we house our population, as we steward up the whole city, well, that problem disappeared. We instituted compulsory vaccination and inoculation of children, smallpox, diphtheria, MMR, and we encourage a further inoculation, often subsidized, Hep B, meningitis, a whole range, and therefore improve public health. We invested in education heavily, and we had universal education, including girls, which is critical, because then each new generation could take better care of themselves and their family. We embarked on a major public housing program. There's a big difference between sharing a bed space in a crowded slum in Chinatown and owning an HDB flat with running potable water and modern sanitation. So the first thing we did was not medical care in the hospitals, but public health. Secondly, we organized our healthcare system and developed it over the years to marry the best of a privatized healthcare system with the best aspects of single-payer models. We started off with a British-style model in the 1950s. Healthcare fully provided by the state, except that there was payment for hospital charges, partial co-payment. Initially, medication prescriptions were free. But one of the first things which the PAP government did when it took power in 1959 was to impose a charge on prescriptions, 50 cents. Even whether it's an expensive drug or Panadol, 50 cents. Token to make sure that people value the medicine that was prescribed, and they won't just take the medicine home, take 2 pills, throw away the rest of the packet, and come back and ask for more. And I think that principle, that healthcare must not be free at point of use, was established right from the start. But over time, the system grew and became unwieldy. Institutions had only the haziest idea of their costs and were not operating efficiently. And it wasn't sufficiently responsive to demand and couldn't deliver the high-quality care that was increasingly the population's expectation. So we restructured the hospitals. We made them autonomous, non-profit operating and accounting entities. We injected contestability as well as principles of financial accounting into the system so that hospitals can provide high-quality services at affordable costs. And this caused hospitals and polyclinics to watch the costs and their bottom line carefully. But we did not make the hospitals private for-profit entities. The restructured hospitals continue to be owned by the government. They are closely supervised by the Ministry of Health. And we supervise them to ensure that they do not compromise on the quality of health care, or neither do they overservice patients, nor do they go overboard in pursuit of profits. So now we have a mature system with the government restructured hospitals making up the majority of hospital beds, but complemented by some private hospitals. Thirdly, we sought to achieve the right balance in healthcare financing between individuals, individuals and the government, between savings and insurance and government subsidies. It's a system which is dynamic and which has evolved over time. We have government subsidies. They are generous. They are tilted towards lower income patients. We make sure that everyone has good access to good health care, including the poor and the vulnerable. To some extent, the subsidies are means tested, but mainly we rely on different ward classes to distinguish different subsidy levels. So if you're prepared to go to a C-class ward, the subsidy is 80%. If you want an A-class ward with a room to yourself, the subsidy is 0. So the government subsidizes a significant part of healthcare costs. The rest is borne for inpatient treatment by what we call our 3M system. 3 M's: MediSave, MediShield, and MediFund. Let me explain. MediSave is an individual savings account where every Singaporean sets aside a portion of their salaries for their own medical needs and for the medical needs of their families. And there are contributions into the MediSave from the worker, from the person himself as he works, from his salary, and from his employer. And sometimes from the government. As a gesture, here's a top-up to your MediSave. I help you, you take care of the money. The second M is for MediShield, which is a catastrophic medical insurance scheme designed to cover large inpatient bills. And every Singaporean subscribes to MediShield unless he chooses to opt out from it. It's a voluntary scheme, but the coverage is good. The third M is for MediFund, which is an endowment fund set up by the government, which is a payer of last resort for people who cannot afford to pay their medical bills, even after using their MediSave and after using their MediShield. So MediSave, personal savings; MediShield, it's a catastrophic medical insurance; and MediFund, if you are really destitute in extremis, there's help from the state. But a medical social worker will talk to you and assess your needs and make a recommendation what you deserve. One distinguishing feature of this 3M scheme is the reliance on compulsory individual savings, and with a restricted role for insurance, restricted only to large bills, not from the first dollar, and not 100% coverage. So there's a deductible, and beyond that, there's co-payment on every dollar, so that the patient always has some interest in watching what is the bill. And this scheme, based first on savings, complemented by catastrophic medical insurance, has been crucial to prevent demand from spiraling out of control, to keep the healthcare system efficient, and to hold expenditures down while providing good outcomes. And I think overall it has provided good outcomes. Low infant mortality, high life expectancy, good treatment standards, and good outcomes for specific diseases, whether it's stroke, whether it's diabetes, whether it's cancer, and so on. So we have what we think is a reasonable working system, but maintaining good health care is a continuing challenge. And the challenge evolves and morphs over time. Because medical science progresses year by year, more papers are published, more drugs are discovered, more treatment methods are developed, more equipment is invented, more genes are found to be related and maybe can be fixed. Our people are getting older, and that means they get sick more often. Demand for healthcare has increased, partly because people are getting older, partly because patients are better informed. They read the internet, they see their doctor, they say, I want that treatment. So when the patient asks the doctor about something, as I did my doctor recently, the doctor says, let me look that up on the internet. But that changes medical practice. And disease patterns are also changing. We now have diseases of affluence rather than poverty. Diabetes and obesity are more common. Tuberculosis, which used to be a big problem for us, especially when people lived in overcrowded slums and were malnourished, is now almost unknown. Although the multi-drug resistant forms of tuberculosis may yet become a new severe threat to us. So we've made various shifts to our healthcare system, and let me just briefly tell you about 4 of them. First, we are providing more comprehensive support to outpatient treatment. Our 3M framework covers inpatient costs and is focused primarily on inpatient treatment. But many conditions, especially chronic ones like diabetes and hypertension, are better treated as outpatient cases and best treated early before complications set in. So we implemented a means-tested subsidy scheme for outpatient treatment called Chiez to subsidize treatment for lower and middle-income Singaporeans at private general practitioner clinics. Secondly, we are replacing Medishield, which is a voluntary opt-out insurance scheme, with Medishield Life, which is a universal and compulsory medical insurance that covers everybody, regardless of age and whether or not he has pre-existing medical conditions. It's still a catastrophic insurance system with deductibles and co-payment, but one which offers better protection and covers a wider range of conditions. And it will give better protection from growing bill sizes. Insurance premiums will be higher because this is a more encompassing scheme. So the government is subsidizing the premiums to keep them affordable, especially for the lower income. But because the premiums are going to be higher than before, it is necessary to make Medishield Life compulsory. Because with higher premiums, there will be more temptation for people to opt out and come back into the healthcare system, and the healthcare system cannot refuse to treat them. Thirdly, we are right-siting our services. In other words, providing services so that patients can be treated at the right level of the healthcare system where they can be best treated, and enable us to provide patients with better and more affordable care closer to their communities. We are improving primary health care with improved access to GPs and to polyclinics. We are building community hospitals which provide therapy and treatment after a patient is discharged from an acute hospital before he is sent home, so that he can be discharged sooner from the acute hospital, where it is very expensive to take up a bed, and where after some time the patient really doesn't need to be there because he's no longer requiring 24-hour surveillance and acute treatment. We are building more nursing homes and working with voluntary welfare organizations to enable aging in place. And we are also structuring our subsidies to encourage patients to go and be treated in the right place, where they can receive the most suitable treatment, rather than turning to acute care by default. Because if you only subsidize acute care but not the community hospitals, it's cheaper for the patient to stay in the hospital, acute hospital, which is expensive to us, instead of going to the community hospital, which is lower social costs. But sometimes it's even cheaper for the patient to be at home. And so we are now experimenting with giving patients incentives to go home and an allowance so that they can help to provide for the care in the home, which is really the most sensible place to be. Fourthly, we are encouraging Singaporeans to take better care of their health. We are mounting public health campaigns to raise awareness of the risks of unhealthy lifestyles. For example, promoting healthier choices for food, promoting regular exercise, or tightening restrictions on unhealthy behavior, like smoking. We are building a clean and green Singapore with access to healthy lifestyle activities, parks, exercise corners, cycling tracks, even as our city becomes more densely built up. We are encouraging an active lifestyle within the communities, especially among our senior citizens. We've launched an active aging program run by our People's Association to bring in senior groups to socialize, to be active, to go for regular medical checks, and to follow up and to take care of their health. And they do brisk walks, line dancing. Some of them even do lion dancing, old folks, Tai Chi. And it's very popular. Quarter million people are participating and enjoying themselves. And I think if you see them, I have not done a scientific study, but they look 10 years younger than those who didn't join. With all of these, nationally today, we are spending about 4.2% of GDP on healthcare. And of that, the government share is 1.6% of GDP, less than half, more than a third. It's overall remarkably low. The results have been good, but I don't think it is sustainable. It's bound to grow over the next 5 years. And we are providing for it. We're providing for it in the budget. We're providing for it, building up the capacity, the infrastructure, the hospitals, the clinics, training the doctors and the medical teams and all the medical professionals, which is the more difficult part of building up our system, and making sure that financially we can afford to pay for this. I believe this is necessary. Our population is aging, and we need to ensure that Singaporeans get the health care they need at a cost which is affordable to all. But we are very, very mindful of the risk of excessive healthcare spending, because this has been the experience in many countries. Once schemes and subsidies are introduced, they are impossible to take away. And once you have vested interest entrenched, can be doctors, can be insurance companies, can be lawyers, it becomes impossible to unwind and reform the distortions and the excesses which are very expensive to society. We are determined to keep our system sustainable. We know there will be political pressure to defer necessary fee increases and to manage the services and to ration them where it's essential. And it's easy for any government to leave the bills to the next generation and to focus on the short-term political gain, or at least avoid the short-term political loss. But if we succumb to this temptation, we'll end up with a system which is non-viable, which will hurt Singaporeans not just financially, but even purely in health terms. Because if your healthcare system is malfunctioning, I don't think it can deliver the level of service and the level of outcomes which we are getting today. Therefore, we are proceeding very, very carefully as we develop the healthcare system, and our Minister for Health, who's here today, has a very difficult job. To succeed in keeping our healthcare system working well, we need a supportive and positive political environment. Because these are political choices, and as a people, we need to be willing to take personal responsibility for our own healthcare and for that of our families. We need to be willing to save for our own healthcare needs and pay directly for our share of the costs. We must be willing to participate in a universal healthcare insurance scheme because of a sense of solidarity with our fellow citizens. So healthcare providers have to ensure that the costs are manageable and deliver cost-effective healthcare, and the government must ensure that by adopting a people-centered approach, which makes sure that even the low-income and vulnerable have good access, but at the same time, the government has to stay hard-headed about the costs and keep a close eye on them and prevent extravagance or waste. We have to be a trustworthy steward, presenting the trade-offs as they are to the citizens and not sacrifice tomorrow for today's political gain. Healthcare is always an emotional and a political issue, anywhere. It's tempting always to make promises and to say, we will do more, we will do better, and it'll cost less, maybe even for free. And so it's important for the government to present the full facts and the trade-offs, because every dollar which you spend on healthcare is $1 taken from taxpayers and $1 less to be spent somewhere else, whether it's on education, on healthcare, on housing, on defense, or on the personal needs of our people. So it requires an honest conversation amongst ourselves and hard choices to be made. Then only can we move forward together with clarity for what our society wants and stands for. So the task in achieving universal healthcare is a very challenging one. For all of us, it is always work in progress. There is no country in the world which considers itself to have reached nirvana, although every country in the world believes that somebody else has a better system. Our model is ours, isn't by no means the only way to do it, but I hope you found what I've had to say about it interesting. And if we continue to learn from each other and to share our experience, we can continue to progress towards the ideal of universal health coverage for all. So I wish you all a very fruitful 2 days of deliberations. Thank you very much.